Hello, and welcome to webinar number 7 in our AFBSS webinar series. Today's topic is initiation and management of medications for addiction treatment, or MAT, in hard-to-reach populations. Now, without further ado, I'd love to hand it over to our presenters, Anika and Andrew.
Good afternoon. My name is Anika Alvanzo. I am a internal medicine trained addiction medicine physician. I've been board certified in addiction since 2010. I am in the Baltimore office of HMA. Prior to joining HMA, I spent 3 years overseeing medical care in residential addiction treatment programs in Maryland and Eastern Pennsylvania. And prior to that, I was on faculty at Johns Hopkins in a number of different roles, ranging from directing the inpatient addiction consultation service to medical director of the opioid treatment program on the Johns Hopkins Hospital campus. So I think, worked at every level of care in the ASAM continuum, ASAM criteria continuum at this point of my career. And I will pass it to the esteemed Dr. Herring.
Great. Thank you. My name is Dr. Andrew Herring. I'm an emergency physician and addiction physician in Oakland, California. I founded and help runs the CA Bridge in our various programs, as well as our bridge clinic at Highland Hospital, which I think is probably the largest low barrier bridge clinic for MAT in California. And I'm just really happy to be here and chat with you all. Next slide. So today we're going to talk about the assertive field-based initiation of buprenorphine, talk about how to tailor the approach to the individual in the setting, the various partners that are there to help you accomplish this, and dig into some of the logistical considerations and challenges with some time left over for Q&A. Our learning objectives today are going to be to describe the 3 different approaches for initiating buprenorphine who are using fentanyl, identify factors to consider when determining the optimal approach for starting buprenorphine, identify your partners in the care continuum to be successful in initiating buprenorphine, and describe at least 2 logistical considerations related to the initiation and management of MAT in this population. Next slide. Next slide. Yeah. These are the anachronisms that you'll see throughout the slide deck. Next slide. Okay, we'll get started and just keep going here with the slide. So why are we here? Next slide. The larger role, so assertive field-based requirements that are rolling down from the state have the background in the traditional brick and mortar behavioral health system is being asked to grow. And it's being asked to grow under circumstances that are very challenging. I feel your pain out there. I know that budgets for service delivery are shrinking in many counties. And at the same time, we're being asked to reach out and find folks in non-traditional circumstances and bring them into care. And so that is happening because opioid use disorder in particular, and more stimulant use disorder, are such massive impacts on the public health that we need to figure out collectively as a way to scale up. And so that is, I think, really the core of what the assertive field-based programmatic requirements are getting out. It's getting out of traditional structures, making partnerships with people that are community touch points, partnering with folks who can find people where they're at and get them started on MAT and follow them through to recovery and success. Next slide. So this concept is new-ish here in California, as well as to the whole population writ large. This slide comes from a New England Journal article led by Nora Volkow, the director of NIDA. And I think it's very important because it presents a key paradigm shift where traditionally many folks sort of thought about this concept of when you're ready, entering into treatment, establishing remission, and then recovery. The introduction is this idea of a protection phase. And the protection phase is defined as something where treatment contact is immediate, meaning no wait. So it happens immediately and it's ongoing. So that's sort of assertive and field-based, meaning wherever you're at. And the core is not necessarily long-term recovery in that moment. It's to prevent overdose death and to prevent and treat associated infections, HIV, hepatitis C, etc. And that protection phase is really where the behavioral health system is kind of growing into and has not been a scale role for the behavioral health system in the past. And that's what assertive field-based initiation is looking at. Next slide. So this slide is busy and it's there just to really communicate. Again, I feel your pain. I know that these metrics are kind of breathing down people's necks, and they're complicated with some big omissions. And if we think about this of just like, what is our role in society? What are we here to do? Who are we starting with and who do we end with? The big picture, right, of, who is out there struggling with opioids in some kind, we actually don't have good estimates at the county level, current state for that, right? The most recent estimates would suggest that over 10% of the US population in the last year used an illicit opioid. Over 10%. So it was close to 11% of the US population of adults has used an illegal opioid in the last year. Over 7% has used fentanyl. That's a staggeringly high number. It's what fits my practice where I run an open access line and the volume is really massive. So I believe it's probably true. And so if you think about that in your own community, it means there's just a huge number of people out there who are not accessing treatment in the current state. Once people get into care, that's where, and they get the diagnosis, that's where the metrics are really kicking in. So you're probably at some level dealing with FUA and FUI, IET, OUD, POD, IET, all of these different metrics that try to kind of shepherd people down and into remission and ultimately recovery. So the assertive field-based work is really all at the top of this cascade and really focusing on finding those people who are at high risk and getting them into the care cascade that later then enters into these metric networks. Next slide. Here's a case. So this is a 41-year-old electrician. Chronic back pain and knee pain was started on oxycodone by multiple physicians in the 2000s. And since 2015, he's switched over to getting pressed fentanyl tablets. He gets online, no problem. Easy for him to acquire them. He's working 46 hours a week. But this morning he was found unresponsive and she called 911 and he came into the ER. Next slide. So this is just a big reminder. It's very easy for us to kind of normalize where we are in the United States relative to the rest of the world and relative to other health complaints. So drug overdose is the number one cause of death in adults under 45, right? That's a staggering thing to say. Each time someone dies from an fentanyl overdose, an average of 38 years of life is lost. So these other causes of death, such as a heart attack, you're looking at a loss of life more like 4 years. So the loss of life due to drug overdose is truly staggering. As I mentioned, the enormous part of the proportion of the population 10% has misused opioids in the last year. And the overall milieu, right, of opioids in the United States continues to be outlandishly out of whack with other developed countries. So if you follow things like, if you actually just track morphine and opioid production from, most of the world's opium begins in Turkey, and other places there, but primarily Turkey, as poppy straw that gets converted into pharmaceutical grade morphine and its derivatives. It's just like this huge proportion of all of that production goes to North America. Why is that relevant? Well, it means that all of our patients are surrounded by access to opioids. The vast majority continue to initiate their misuse with a opioid analgesic. So 75% of the people who use illegal opioids begin their use of illegal opioids with a opioid analgesic that was either prescribed to them or someone else, or a diverted one. So the general temperature of the epidemic is just red hot. And it's just to remember that this is a very, very red hot moment. And that is the drive. If we are going to change this fact that this is the number one cause of death in 2045, we have to take very large scale action, which is driving the assertive field-based movement. The tool that we have, the primary tool that we have, is buprenorphine. Methadone is also a tool. It is good to understand it's inherently less scalable. We're not going to have 12 million people on 120 milligrams of methadone a day. It's just not scalable or feasible. Buprenorphine is scalable due to the pharmacologic properties of its partial agonism that make it safe and feasible to scale. Next slide. So this is a example for Alameda County, and at Bridge we're creating the report cards, so to speak, for all of our various counties in California. And so what you can see here is that we have a target gap of probably about 30,000 people, right? And that's the gap between the people who could benefit from access to MAT from those who are getting it. Our uptake rates, are around 13% of the folks who we estimate could be benefiting from it are getting it. So it's just a long way away from where we should be. In California, in your county, you're probably pretty similar. These numbers don't vary that much from county to county. Next slide. So emergency department visits, these are high risk, right? This is like the ER is the low-hanging fruit to reach high-risk people at high volume. I love, I've started a nonprofit about a street medicine. I love it. It's amazing. And it sees very small numbers of people. ERs are 24/7. They're always open. They're always free. They've got food and clothing and places to lay down. They're universally recognizable no matter what language you speak. You just can go to the ER. And so that means we attract a tremendous number, tens of thousands of people, hundreds of thousands regionally, who go to the ER and have a substance use disorder. So if you're going to do one thing to initiate a assertive field-based program, it would be to partner with your ER to identify and initiate treatment of substance use disorders with your local ER. That is the low-hanging fruit. The risk for overdoses, in particular in the ER, is just really staggering. So there's a 5% 12-month mortality. This is this incredibly high-risk group of people. The idea that people after overdose don't want help is just simply not true. One of the leads on a national project that looks at initiating buprenorphine by paramedics. And what we see is that people who overdose are in trouble and they want help. When we approached people in the ER here in California as part of the CA Bridge program, we found that 85% of people with opioid disorder wanted treatment. right? They wanted convenient, readily accessible, few strings attached treatment. And that is a real counterpoint to myths that folks in crisis aren't ready, quote unquote. We really see that they are both are ready and want treatment. Next slide. So there are green shoots all over California. This is a tricky one, right? It's the behavioral health system in California cannot possibly take on MAT for the whole state. There's just not enough providers, not enough facilities. So this is about physical health and drug Medi-Cal coming together to meet the needs of the community. The vast majority of people don't know that opioid use disorder can be treated by their primary care doctor in an FQHC. They think that opioid use disorder treatment means they've got to go to a 30-day treatment, residential treatment or something like that, which as a busy electrician, this person certainly can't do. But what the county really can do is hold that accountability for transitions between components of the system that is letting the public know and giving them assistance to access care that may or may not actually be funded by the county. Meaning that if someone gets MAT at an FQHC, that as a county person, you can say, you did your job. You got someone into evidence-based effective care. The nice thing is that when they're at the FQ, it's the physical Medi-Cal with the federal match that's paying for the services versus the county. The piece that's missing is that outreach to the community and letting people know that this entire system is available to them. And again, I think that is really the low-hanging fruit for driving this development cycle for clinics, because clinics really won't get started in the FQ setting until there's a consistent demand. And I think counties are really well positioned to facilitate and create this steady demand that then drives the development on the FQ and primary care side. Next slide. So starting buprenorphine. Next slide. So myth one, buprenorphine management is complicated. So this is just really important. Fentanyl, all these sort of things like that don't embrace the idea that buprenorphine is complicated. Next slide. It really can be simple. And so everything is moving down towards simplification, simplification, simplification. This is a great slide. Thank you, Philip Coffin and the team at the San Francisco Department of Public Health. This is where the core thing, the core options that we're going to go over in great detail are, if you want to try bupe, right, you can try, there's new injectable versions that have a lot of convenience aspects to them. There was kind of a concern that people wouldn't want injections, the needle, etc. Those have really not turned out to be the case. But the other option, right? So, but those aren't available everywhere. But if you do have them, they're great. I would really suggest promoting and encouraging injectable or long-acting injectable buprenorphine into whatever programs that you're working with. If you're not interested in injection, we basically either do a high dose, so you're in withdrawal, you've got your sweats you haven't used in 24 hours. This is the way the vast majority of the world starts buprenorphine. It has not stopped being the primary method. It's very simple. You wait, you go into withdrawal, and you take a big dose. Classic. Now, the other thing is for folks who are they're engaged with you, they're coming back, but they just don't really want to stop using opioids. And they want to be able to start buprenorphine without having a period of abstinence. This was sort of considered previously a no-go zone. Now we're really understanding that people can kind of trickle in their buprenorphine. They can continue to use their illicit opioid as they're sort of gradually adding in brick by brick adding in the protective and helpful buprenorphine that's triggering downstream changes in their systems and eventually stop using and go into full dose bup. And so these are the basic strategies that we're going to be talking about later. Next slide. The first technical way to sort of describe this low dose trickle is low dose initiation with opioid continuation, and that's the ASAM preferred terminology. Next slide. This is the kind of core idea where the key thing, and we've really put up front, is in this treatment bundle, you continue using opioids. So this is not just using itsy bitsy pieces of buprenorphine, because if you do that, you're just going to go into withdrawal, right? There's an opioid deficit that has to be paid, every single day. That debt does not go away. So that means if you're admitted to the hospital, this is what we do, is we just prescribe you morphine, extended release, and breakthrough. And then on day 1, we take 0.5 milligram of buprenorphine and just schedule it every 3 hours. Then we ramp up to 1 milligram every 3 hours. And then by day 3, you're ready to go to a full dose of injectable bup, all the way continuing to get opioid. So for some folks, this is like, whew, yawn, seen this before, that's great. For others, this concept of buprenorphine and being given together with morphine, or buprenorphine being taken by someone who's continuing to use fentanyl, could be like a mind blower. So it is very cool and new in the addiction space. I'm a pain specialist as well, and this was always kind of known in pain medicine that you can mix buprenorphine and full agonist opioids. The trick is in the timing and the dose. So that has been kind of a new thing in treatment that can enable you to get the treatment momentum going before someone goes into withdrawal. Maybe when they're pre-contemplative about the whole picture, they're just not ready. You can say, hey, well, let's just get started today with a little bit. Let's put a Butrans patch on. Let's give you 0.5 milligram. We can get this going and talk to you tomorrow and see where you want to go. Next slide. This is a more formalized, protocol, which is very similar. Same idea. I've done a lot of work with folks all over the country, and you will find that there are probably 50 different protocols for this, where the take home, it's just basically whatever way makes sense for them to trickle in a little bup, right? However you can get them to do it, that's great. This is an example protocol. This can be used for a lot of your street, shelter, other places where people maybe aren't in withdrawal but want to get started on treatment. The key thing is they're going to have to keep using full agonists, and that's the thing to remember. So if you're doing this as an outpatient, it means your, quote, treatment plan involves expectation that they will continue to use illicit opioid off the street, which is a big question. Like, is that really treatment then? Have they really started? It brings up a lot of these very legitimate, I think, philosophical quandaries. And it is not at all the best thing to do. It could be the best for some person, but I don't want to give the impression that somehow we think it's superior to the traditional method of waiting, going into withdrawal, and taking a few dose. There's a real equipoise between all of these from a ethical and clinical and philosophical standpoint, I would say. Next slide. High dose. Next slide. This is just the core. And it's, again, these are just these motivational interviewing muscles that I don't want people to forget about. If you can support someone to enter into abstinence, that is a good thing. Dropping and not using, is something that while we want to promote respect for people, for harm reduction, for autonomy, we also have to remember that if you can get to the motivational, structural, social, personal circumstance where you can stop use, that is good for you. It really is. So in this protocol, you're simply going into withdrawal. You will hear a lot about fentanyl withdrawal being different. It is different. Yet I can tell you as the one of the lead authors on the largest prospective trial of buprenorphine initiation ever done in the United States, that there's a lot of fog out there that when you really get down to it, fentanyl withdrawal will occur at a pace that is quite similar to other opioids. And when true manifestations of physical withdrawal are there, typically two objective signs, they're diaphoretic and their pupils are big, or they're yawning, or they have lacrimation. When you've got those two of those signs, they tend to go together. You're ready to you're ready to start buprenorphine. You will hear like they hadn't used for 4 days and they had severe withdrawal, and I gave them buprenorphine and they precipitated withdrawal. That's probably untrue. And I know this because when we have under rigorous and experimental context in the ER, where you have repeated measures of cows and a lot of attention on people, we really find that if you just get them to a cows of 8 with two objective signs, 1,000 people, the rates of precipitated withdrawal are very, very, very low. And that is in people who are primarily using fentanyl. So don't abandon the higher dose buprenorphine. And as soon as they're on it, you really want to ramp up to the highest dose possible for most people who are using fentanyl in particular. So 32 as your starting dose is perfectly reasonable. So being stingy with bup doesn't make sense from a public health, pharmacologic, or individual treatment basis. Next slide. Okay. Thank you so much. Nick will take it over.
Okay, and I just saw, yes, it's answered in the chat. So I'm going to start talking about the direct to inject initiation of buprenorphine as the third strategy for starting people on buprenorphine, and we can go to the next slide. So as my colleague mentioned, we have two new tools in our toolbox. We have two different formulations of long-acting injectable buprenorphine, Brixadi and Sublocade. Both are approved for severe to moderate opioid use disorder. Brixadi has either a weekly, every 7-day formulations, different doses, or monthly, every 28 days. And Sublocade has two different strengths of every 28 days or monthly formulations. These medications are subcutaneous, so they go right in the fat area under the skin. They can be given in multiple areas, and that are listed there on the screen for you. It's important to know that it takes a little while for the dose of the medication to build up in people's system. So it's not uncommon until people get to a steady state that some individuals might require additional sublingual buprenorphine doses until they reach that steady state level. The package insert for both of these medications, for individuals who are already being treated with sublingual buprenorphine, most of them can go directly to the monthly injectable formulations of either Brixadi or Sublocade. For individuals who are not currently being treated with buprenorphine, the current recommendation in the package inserts for these medications is to give at least a single dose of 4 milligrams of sublingual buprenorphine. And if the individual tolerates that, meaning they don't go into precipitated withdrawal, then you can proceed directly to injection. That's the package insert. Let's go to the next slide. So why might you use this formulation? One, individuals don't have to remember to take medication daily. I think we're going to talk about there's less concern for you. We don't have a lot of reasons to be concerned about diversion, but if that's a concern for you, or if there's a concern that the individuals may not be able to safely store their medication, this might be an option. It decreases the frequency of office visits. So if individuals have to come and if they aren't insured or they have to pay a copay every time they're seen, this decreases the frequency of office visits. And for individuals who are making a decision to discontinue medication, there is some evidence of kind of ease of discontinuation if the patient decides, makes that decision to discontinue. Next slide. Reasons that you might not use long-acting injectable buprenorphine. One, they're newer to the market and they are significantly more expensive than the sublingual formulation of buprenorphine. And so if somebody's uninsured, or if it's you're looking at how you're going to budget and pay for this, that may be one reason that you might not particularly use this formulation. They are required to come from a specialty pharmacy. So the logistics in terms of even getting these medications, you have to have a specialty pharmacy. They cannot be picked up by the patient. They have to go directly to the clinic that is going to administer the medication. And so the pharmacy logistics are a little more challenging, but easily worked through. So we talked about people not having to come as often, but maybe particularly earlier in treatment, we do want people to come more often. We do want more engagement, more opportunity to engage with the team and make sure that they are doing, that they are hopefully have at the right dose, that we're controlling their withdrawal symptoms and cravings. I'll be very honest with you, both of these medications burn going in. Right. And so there is some discomfort with the injection, even though they're subcutaneous, there's a burn when they go in. And anytime you introduce a needle or you're breaking the skin, there is always the risk of infection. And we use sterile procedures in terms of we clean the skin appropriately and we use gloves. But anytime you introduce a needle, there's the risk of potentially introducing infection. They're newer to the market, and so our data on the long-term benefits are less clear. And there's quite a bit of variability in the drug delivery experience from individual to individual, and sometimes even within the same individual, there may be some variability in drug delivery. So those are reasons that you might not consider it. But I will say we've got increasing evidence that these can be a very good tool in the toolbox for treating individuals with opioid use disorder, particularly those at high risk. And with that, we'll go to the next slide and we'll talk about that. So what I said, so direct to inject initiation of long-acting injectable buprenorphine is giving the medication without first giving that sublingual dose of buprenorphine. So I said the package insert for both of those suggests that you give a 4 milligram sublingual, at least a 4 milligram sublingual dose first. Direct to inject, there's no sublingual, you're going directly to injection. And this approach has primarily been used in individuals who have not done well with more traditional approaches of initiating buprenorphine and those at high risk for overdose. The literature, I want to be very honest with you, the literature on this approach is limited, largely based on retrospective case studies. And so at this time, there is no standardized approach. And just to be honest with you, what has happened with the rapid change in the drug supply is that often our clinical practice has had to evolve before we've had the research to really guide us how to evolve the practice. But over time, with Andrew, I'm sure has treated thousands of people in his ED. And so over time, you develop expertise in managing individuals. And so this is another one of those approaches where our clinical practice has kind of changed in advance of our research. And so the literature is largely based on retrospective case series. And so there's no standardized approach. What you see on the screen is one example of an approach. You may consider this, and you may have to be comfortable with kind of developing your own approach based upon what's happening with the population that you're working with, what resources you have available. But what we do know from the publications that have been published, the risk of precipitated withdrawal is actually fairly low, anywhere from 3 to 7%. And so, again, when you're thinking about individuals who are high risk, have been difficult to get onto buprenorphine via other approaches, it's one to consider. Prescribers who take this approach are going to have to be flexible, be prepared to adapt and modify your approach to find the one that's best. And then also recognize that this is another one of those times where you're going to have a conversation about risk benefits and have a shared decision-making conversation with the patients that you're working with. Next slide. So this is another, again, so that we showed on the last slide, we had one approach. This is one approach that Andrew and his colleagues have developed. And these were individuals who were seen in the emergency department. So in this approach, waited till individuals were in some had some evidence of withdrawal, again, using that COWS score, the clinical opioid withdrawal scale. And after they achieved at least a score of 4 higher and at least 6+ hours since last use, then they gave an initial injection of buprenorphine, Brixadi, 24 weeks, so the weekly version, 24 milligrams, one-time dose, and then linked them to care for ongoing treatment. Next slide. So what are the criteria for tailoring the approach to the individual in the setting? And we can go to the next slide. So first, it's going to be one: what substances is the individual that you're working with using? Are they using high potency synthetic opioids? In other words, fentanyl and its analogs. What have been their prior experiences of withdrawal? What have been their prior experiences with medications for opioid use disorder? Particularly, have they tried initiation of buprenorphine before, and what happened with that? What is their ability to understand and follow directions? So some of these approaches that we've talked about require people to be able to follow some certain steps, particularly in an outpatient setting, in terms of gradually increasing the dose. Now, there are things that we can create and tools that we can give them to help simplify that for them, but there has to be some ability to understand and follow directions. What's their ability to secure the medication? And what is your plan for continuation post initiation? And then ultimately, really what it comes down to is you have that risk benefit conversation, you have a shared decision-making conversation. What are they willing to accept? I mean, let's be honest. What are they willing to accept, and what are you able to do? And that's often the primary driver for picking an approach. Next slide. So in terms of system level factors, one, what is your prescriber availability? We'll hear later on about some different approaches for increasing prescriber availability. What is the prescriber's expertise and comfort? So we mentioned some of these approaches are newer. We don't have as much literature to guide us in a standardized approach. And so what is the prescriber's expertise and comfort? What is the availability of medication? Again, recognizing that for some of the formulations, you need there may be additional hurdles to jump through to get access to the medication. And then what can you pay for, right? What funding is available for these medications and the different approaches that you want to use? And again, we don't just want to start people on medication. Absolutely, starting is important, but how are we going to continue them on these medications? Next slide. And so for the sake of time, we're just going to ask you to respond in the chat. So harkening back to our case of Mike, the 41-year-old electrician who's been using pressed fentanyl tablets. Wife has found him in the midst of an overdose. He's received naloxone, and now he's in the emergency department. In the chat, give us an idea of what type of approach do you think might be good for initiating Mike on buprenorphine. And as we talk about this, we'll also try to respond in the chat as well.
So first question that we got, is it true that the LAI has a natural taper process so users do not have to continue taking it after 1 month?
Yes, it does have a natural taper process, which is why we say it may be easier for discontinuation. I don't necessarily recommend that somebody stop medication after a month. When I have conversations with patients about initiating medication, just because of what we know about the long-term neurobiological changes that occur and the time it takes for improvement of some of those changes, my typical conversation is that we recommend you being on it at least a year. And at least a year, and that's minimum, before we start talking about discontinuation. Because in addition to addressing your substance use, we want to address all these other things. Do you have coping skills? How do you manage stress? And so, I don't typically recommend that somebody get a single dose and then discontinue.
The next one says typical Sublocade dosing is 2 300 milligram doses, then a decrease to 100 milligrams thereafter. Is it possible or recommended to give a 300 milligram dose every other month to someone instead of the 100 milligram dose every month?
So what I will say is typically, so there's a number of things. So one, yes, you typically start with 300 milligrams and then you can drop down to 100 milligrams. One, everybody does not tolerate that drop down. And so it is not uncommon for some individuals to remain on 300 milligrams ongoing instead of dropping down to 100 milligrams. And, I don't, Andrew may have a different experience. I don't necessarily recommend that people come every other month. I would, particularly when we're talking about keeping, especially early on when we're trying to get them to steady state. And so I don't know if you have other thoughts, Andrew.
Sure. Yeah. Mark Greenwald is a pharmacologist who was really kind of the architect of Sublocade, and I've been working closely with him for a long time. And that idea of the two 300s and 100 was sort of an idealized expectation pre-fentanyl. So what you've seen now, and actually, is that if you'll look at Sublocade, the guidance has been recently changed by the FDA based on a study they did in Australia. So now for folks whom you suspect of fentanyl use, actually the protocol is 300, 300, and then a week later another 300.
Right.
So they're really going the opposite direction, with the recognition of just tons and tons and tons and tons of data all pointing in the same direction, which is that more buprenorphine leads to lower overdose deaths for those people. And that's just the rubber meets the road.
Yeah, and there was a study, again, I think overseas, that looked at individuals who were on long-acting injectable buprenorphine, and again, particularly individuals who were using fentanyl did better on the higher doses of Sublocade.
The next question was just about success rates for direct to inject patients, and if there's a rough percentage that are lost to follow-up before the third injection.
The challenge is that the literature is retrospective, right? And so typically when we look at something, we make recommendations, we're looking at a randomized controlled trial. But there of the publications, some of them have had, in terms of people coming back for their third dose, up to 75% of individuals coming back for that third dose. There were, so anywhere from 50% at 6-month follow-up. And so, with the limited information that we have, certainly no worse than other approaches for initiating medication.
Yeah, I just was going to say that the protocol that we showed there, the bridge protocol, is based on the NIDA trial that I helped lead, that was published in JAMA, which is a prospective randomized control trial of 2,000 people, and it's very, very high quality data. And it actually showed that there was equivalence between sublingual initiation and extended release or long-acting injectable. So in that study, we found a 40% retention rate at 30 days. What the extended release formulation allowed us to do is to initiate that at a lower COWS. So that is a very important but subtle distinction, is that these long actings enable you to reach more people. And a potent reminder that while they're exciting and new and different, the core effectiveness of long-acting injectables at this point in time is not very different from traditional treatments. This myth comes from a lot of thought and discussion with people around the country around this core question of why is buprenorphine not more available? Like, why have we collectively, all of us on this call, all of the stakeholders above us, why are we at this point where only 10, 13, 15% of folks who are suffering from a use disorder have access to buprenorphine? Next slide. I think that one of this core things is, whether or not we admit it or not, there is a misunderstanding that buprenorphine is like oxycodone or like another agonist, in that if we just are too uncareful, if we're too quick to prescribe, if we're too quick to use high doses, if we're not careful enough with who we select and how we provide surrounding supports, if we just put it out into the population, that harm will occur, that it will be diverted, it will be used by people to have fun and to party, not for its intended purpose, and will actually make the whole problem worse. What we've seen now in Malaysia and Finland and very famously in France, whereas if you just show up with a dump truck and just tip it over and just dump buprenorphine into the population, overdose deaths go down. And so this was this dramatic example from France where there was no plan. They did not have any of these. There were no webinars. There was very little regulation. It all went out through generalists. There were no specialists. It was just primary care docs, pharmacies, just making it available to anyone who wanted it. And with that, they had a 96% reduction in overdose deaths from heroin. A very strong testament to its effectiveness. Next slide. So then this other one is that buprenorphine is not recovery. It's just really treating, one drug addiction with another drug. Next slide. And so you see this again, this constant just sort of stinginess, in wanting to lower the dose or get off as soon as you can, and all of these things. And what I want to communicate is that buprenorphine truly is a unique technology, that for 2,000 years, we've struggled with the harms and benefits of opioids. You can either someone who has become habituated or addicted or dependent or whatever word you want to use that describes the same thing. You can either maintain that person on opioid for the long term or force them into abstinence. Buprenorphine creates this third opportunity where it's this partial detoxification. And I use that word intentionally to mean that there is a physiologic, pharmacologically driven recovery of your opioid system that has to occur for buprenorphine to work. And so that's why it really does mark this halfway step from abstinence to full agonist that is very different from methadone. And that in that place, you really can communicate to your providers and to your patients that this really is a demonstrable step forward in terms of your own internal physiologic healing that buprenorphine supports. Next slide. The journey is messy. Okay, most of us, in the specialty behavioral health are way out on the right side of this slide. This is some work I did. I published in JAMA looking at every single emergency department initiation of buprenorphine in the state of California through the CURE system. And what you see is that, at one lens, it's very successful. You start 9 people on buprenorphine out of the ER, and one of them will stay in continuous treatment for 180 days. That's incredibly effective from the medical lens. But then you also see that most folks are going to fail on their first try. So that's really the space of assertive field base, is working with all these folks who are trying it once, trying it twice, trying another time, cycling back and forth, providing the opportunity for the one who's ready, the one who is responding, to continue on for sustained recovery. Whereas traditionally, most of our focus has been on the folks who've really made the commitment. What we really need to do is move upstream and really think about all these folks who are more ambivalent at multiple touch points throughout the community and reach them. Next slide.
Yeah. And I just, as we are transitioning for our last few minutes to talk about the partners, I just want to say that initial try unsuccessful is not different than many other behaviors that people try to change. Losing weight, developing an exercise routine, taking your other medications regularly. And so we tend to hold out individuals with a substance use disorder as over here and being, outside of the norm. That's very common with other changes in behavior and other chronic diseases that people experience. And so just wanted to say that. So in the last few minutes, we're going to talk about the partners as you're developing your AFBSS models. Who needs to be at the table and who needs to be part of that model? So we can go to the next slide. So as we have heard from my co-presenter, Andrew, a substantial proportion of people with untreated opioid use disorder are presenting to the emergency department. And so including those who would be appropriate for AFBSS services. And so in this, your emergency department is an essential partner for you as you are developing your model. So engaging and partnering with your local emergency department should be an essential component. Similarly, as we heard, emergency individuals who are working in emergency medical services, there are some EMS services that are now initiating buprenorphine in the field. There are others that have a post-overdose response team. So once somebody has been seen by EMS or treated by EMS who has responded to an overdose, we'll send teams out into the community to do follow-up. And so partnering with your emergency department of first responders and crisis services are going to be critical partners. Next slide. Similarly, people who are already working with this patient population, for example, syringe services programs, integrating buprenorphine prescribing into SSPs, whether whether you've got the provider at the SSP in person or using telehealth to bring the prescriber in and delivered and integrated into the other services that are being provided at the SSP. And we have data to suggest that 43% buprenorphine retention at 6 months. And so these are effective ways at engaging individuals. And the benefits are not isolated to substance use. Also see reduction in other HIV risk behaviors when we are integrating medications into these already existing services. Next slide. Similarly, street shelter medicine. So we already know that individuals who are experiencing homelessness are at significantly higher risk of substance use and substance-related mortality. And so, and we know that they have significant difficulty in accessing care. And so if we can integrate prescription of medication for opioid use disorder into teams that are already going out and serving these individuals on the street, that is another way those are additional partners that should be at the table. So if you've got street medicine or shelter medicine teams in your community, you should be partnering with them and consider them. And that's actually what AFBSS is, right? Taking the services to the street, to the individuals, to the encampment where people are being served. Similarly, you can see fairly good 6-month retention. And so it is an effective strategy. Next slide. So we heard that Andrew operates bridge and open access clinics. So these are clinics that offer low barrier services, either initiation of medication or continuation and stabilization for people who were maybe seen in the field, seen in the street, or seen in the emergency department. And often include interdisciplinary teams who are providing a number of different wraparound services to individuals, again, with the goal of either initiation or stabilization and then transition to long-term ongoing treatment. Next slide. Federally qualified health centers serve predominantly low-income and uninsured populations and are a critical partner. And you can see here just the data that shows they have the ability to deliver long-term treatment more than 2 years with high retention rates, 69% annually. But we also know, as Andrew said, this is an area where we've got room for improvement. Between 2017 and 2023, the prescribing of MOUD went from 10 to 25%. That's still a lot of people who are not getting access to treatment. And there were significant disparities, including individuals who were unhoused were less likely to be prescribed MOUD, and those with higher populations of minoritized individuals. And so they should be a partner, but we need to work with them in terms of mitigating those disparities. Next slide. Additionally, the needs of individuals in this population often extend beyond medications for addiction treatment, and thus engagement and integration of care management, community support, and social determinants of health providers is strongly encouraged. One project or program specifically I'd like you to consider is Enhanced Care Management, or ECM. ECM is a statewide Medi-Cal managed care plan benefit in which high-need individuals are assigned the lead case manager with the goal of improving care coordination and health outcomes while reducing reliance on emergency rooms. Again, an initiative that aligns very heavily with AFBSS services. Target populations for ECM include individuals experiencing homelessness, those with serious mental health or substance use disorders. And what we are finding is that integrating ECM into AFBSS service models with some providers actually becoming ECM providers as well is integral to providing whole person care for this high risk, high need patient population. And with that, I'll go ahead and kick it back to Andrew.
Footprints of the partnership models. So behavioral health services was, or behavioral health services were originally developed and funded in an environment where substance use disorders, and particularly opioid use disorder, was much less prevalent. Currently, data from 2024 show that 11% of the US population has used an illicit opioid in the last year. Over 7% have used fentanyl. That is a tremendous number of people. There is no possible way that the current behavioral health infrastructure funded through the drug Medi-Cal organized delivery system could reach all those folks. It just can't. So that's why I have this slide to just sort of think about the various footprints. So the number of people in a given community who have a substance use disorder who are interacting with the behavioral health system is over on the right hand of the slide. Then these other non-medical, non-behavioral health touch points, jails, shelters, etc., probably are touching more people on a daily basis. And then when you really step back, probably the largest number of people are actually touched by medical services, particularly the ERs, that see tens of thousands of people each year, open 24/7 with a federal mandate to see whoever walks in the door. So the providing a bed, providing meals is a big part of what ERs are in the current state. So there's a little bit of a mismatch where the team that's asked to reach all the folks who are suffering from a substance use disorder actually doesn't have the workforce and manpower and footprint in the community to effectively reach all of them. So the way to do it is through partnership. Navigators, I think, are the key to this. Like, how do you architect complex partnerships across many different transitions of care, across not just different institutions, but whole different types of institutions, going from jail to a shelter, or a shelter to an ER, or an ER to a residential treatment, to a medical respite, to a street team. Those are all very different institutions, different funding streams, different missions. Braiding that together into a cohesive patient experience that supports them to advance from use into remission and into long-term recovery is very difficult just to pencil that out on paper. And this is where actual human beings are probably our best asset to accomplish this very technically difficult task of coordination. Navigators are community health workers that are specially trained and specially dedicated to understand the lived experience of someone suffering with a substance disorder and come at the work with a non-judgmental, compassionate approach with a commitment to, by hook or by crook, finding a way to influence, nudge the system to provide them with evidence-based care when they need it. That means that they are utilizing medications for treatment of addiction whenever appropriate, and that they often will have a whole Rolodex of back numbers, back doors, workarounds, all these little things, these multitude of ways that you can get someone in same day or rescue them when a prescription has run out and they need a new provider. And all of that you really can't put down into a treatment locator database or any kind of static inventory. It needs to be this dynamic interaction where you've got teams of navigators that are constantly on top of what the actual access picture is in the community and are feeding that back into individual patients and making it happen. So navigators are, I think, probably the single most cost-effective way that a county could spur, catalyze, and support the implementation of an assertive field-based approach to substance use disorders. This CA Bridge Connect is really leaning in hard to this, where we recognize that to a fault, traditional thinking has focused on discrete episodic treatments where you get treated for a day in the ER or 30 days in residential or 90 days in residential, or some other episode. But no one is actually accountable to the many, many transitions of care that someone will have over their life as they move from use into recovery. For opioid use disorder, we know that the median time of entering into treatment is 10 years. And when we follow people out 10, 20, and 30 years, over 80% will relapse. So there's a need for someone to be connected to someone in the long term when they're on those near misses, they're about to relapse, or there's some close call, that there's an availability present there that they can access that then can distribute whatever their need might be into this complex provider system where some providers are well positioned to provide a rescue dose of methadone at 2 o'clock in the morning. That might be the ER. Another provider is well positioned to integrate that methadone treatment with behavioral health in a setting that protects you from cues of other people using, i.e., sober living or residential treatment. So having a centralized single access point in the community that is staffed by navigators, I think is probably the lowest hanging fruit to, with a relatively low budget, to catalyze and support a regional dissemination of access, low barrier assertive access to MAT without having to build brick and mortar new services. You're basically building up the staff that'll be open and available to the people in need and will organize and stitch together existing treatment programs. If someone is able to get into their FQHC, that treatment visit will be covered as part of their physical Medi-Cal benefit and doesn't need to be paid for by behavioral health dollars. The piece that's missing is that navigation to get there. So this is the partnership model where you have the behavioral health services and the managed Medi-Cal plans combining with collective self-interest to fund a centralized open access telenavigation. I almost think of it like roadside assistance when your tire pops. This idea that everyone in the community should have a number they can call when they're ready, when they have need, and they'll get this just-in-time service, this idea of JITE, that suicidality has really worked out. So just-in-time adaptive intervention. That's what a navigator does. They're just-in-time, meaning they're available. They call or text, you pick up the phone, and they're adaptive. They don't have a preordained idea of a treatment pathway like you're going to go residential, you're going to go methadone, you're going to go bup. No, you follow the patient. What do they need? Do they need harm reduction plus bup, or they need residential treatment? What do they need? That combination of medical services, jails, shelters, and behavioral health services can be put together with the navigator driven by the patient preference. And that will generate this outcome of assertive field-based access to substance use disorder services. We've piloted this. We know it works. In Alameda, by creating a number where anyone struggling, particularly with opioid use disorder, but any substance use disorder, could call in and reach a non-judgmental, confidential navigator who wasn't there to do an ASAM assessment and place them in residential or IOP, but was there to meet their immediate needs of harm reduction and or MAT initiation and or planning for behavioral health treatment in residential or other setting. By having that availability, we saw that our emergency department was utilized much less. So the number of ED visits for an opioid-related crisis went down by 60%, whereas the community access to buprenorphine went up by nearly 300. So this is this sort of mythical quadruple aim of healthcare where the patient gets good experience, the providers feel like they have a meaningful job, you lower costs and you raise quality. Well, this is really what it looks like. Patients have a great experience. The ER is more appropriately used. Some folks are sent to the ER because that's where they need to be. And many folks who don't need to go there don't have to wait in line and they can just call and get services. So this utilization of telehealth and telenavigation is really truly a game changer to create assertive field-based access. That was in Alameda. In San Francisco, they've got a really cool program that Dr. Noel Martinez is the brains behind this, and it's very cool, where they are in the milieu of in very intensely high use area in the Tenderloin, where navigators are on site, in the evenings, literally, shoulder to shoulder with people who are selling fentanyl. Like they're right there and they're kind of competing with them, so to speak, and saying like, hey, if you don't want that, we have treatment. And when someone takes the bait, they're interested in maybe moving away from that life towards another one, away from harm and towards wellness. They literally fire up their iPad and get the doc or the PA or the NP onto the iPad in real time to do a clinical visit right then and there via the iPad, and then prescribe to a local pharmacy. So many people are getting extended release or long-acting injectable buprenorphine through a facilitated iPad visit in the street. That is a wonderful model that you can imagine being replicated in all kinds of other high-touch environments. And a partnership model might be that the physician can be paid for through federally qualified healthcare center funding. So that wouldn't need to be on the behavioral health bill. But then the navigator being out there, that might be a harder one to fund from the FQ standpoint. That could be a way that the funding streams could be braided, and the county could fund the navigator, the technology stack, and then the FQ funds the treatment, and Medi-Cal funds the pharmacy benefit for the payment of the buprenorphine, and everybody wins. The centrality of telehealth here is really important. It's not complicated. And this is one of the things that I know that the general public doesn't understand this. I know that most patients don't understand this. And there might be many in the audience who don't really fully haven't seen how simple telehealth is for buprenorphine. When COVID came along and the clinic that I run, immediately went from this thriving, dogs, families, busy mat clinic to a ghost town with a screen full of names I was going to call. I just thought, oh my God, this is the worst thing ever. What a disaster. I then quickly realized it was a miracle that we were able to reach more people more efficiently than ever before. And our clinic, and I've seen clinics all over the country, have just exploded because telehealth is so convenient. It's so patient-centered. We have all of these folks who are really struggling with opioid use disorder in particular, who are dropping their kids off at soccer practice, they're going to work, and traditional models that require a lot of attendance, a lot of physical attendance and hours in treatment just don't work for them. Likewise, we have folks who are too disorganized and have too many challenges to make appointment needs. So the drop-in calls really help them. So both ends of the executive function spectrum really get helped here. Phones are readily available through Medi-Cal and other benefits. So they're quite cheap. So the equity problem is certainly existent, but we've found the vast majority of our homeless patients in Oakland, California have access to a phone. And I suspect that's true in many communities. With telehealth, you can beam in reach to any number of programs. So syringe services programs are just coming out with the results of their pilot programs to integrate mat access, and they're wildly successful. Residential treatment programs that are just getting off the ground with MAT. They don't have a cultural history of understanding how MAT, buprenorphine, methadone, and other MAT works. That can be jump-started, kick-started, supported, and amplified by a centralized expertise that could, again, be coming out of an FQ context, reaching in. Homeless teams, you might not need to pay for an addiction specialist to join the homeless outreach team. You could simply partner the homeless outreach team with a centralized telehealth addiction specialist operating out of a local FQHC. I will make a little pitch that I really do believe that FQHCs are the way to go here. The for-profit companies, of which there are many, they struggle for a financial model that works because they do not have access to FQHC billing. So while some of their services might be excellent, in general, I would really support the development of telehealth services within the existing safety net infrastructure versus advocate for contracting anew with others. That's a little bit of my editorial. In terms of outcomes, there was early thought that maybe telehealth was a thinner, more superficial service that was inferior to a comprehensive multidisciplinary model. What we're learning is, again, opioid use disorder in particular is about the long haul. It's about following someone for 10, 20 years and being there with them, when they slip up. The inevitable relapse occurs. How quick can we turn that around and get them back into treatment and avoid opioid-related harm or death? So instead of inferior outcomes, we're actually seeing improved outcomes, some quite dramatically, where patients who are offered telehealth have been found in some studies to have nearly 30% higher retentions and 30% lower risk of overdoses, which would correlate with their retention and treatment. With opioids, it's about retention, it's about engagement and being there. Any amount of bupe is going to move you towards wellness, away from harm, even if you're using on top of or in addition or sporadically. It's very clear from the data that any amount of bupe is making you safer. The more bupe, the more safe you are. And that's a big thing to kind of wrap your head around, is how important just the simple availability of buprenorphine or methadone for someone who chooses that is to long-term survival and mortality benefit. And telehealth is just the way to be there in someone's life when they need it. You know, they're in trouble, they can just call. And supporting systems that create that availability is the future for successful, large-scale, assertive field-based programs. So the take home here is behavioral health departments are the essential catalyst to drive system change. The FQs are not going to do it on their own. The jails are not going to do it on their own. No, the shelters are not going to do it on their own. Now, the hospitals are not going to do it on their own. They need someone who really deeply cares about specifically people suffering from substance use disorders, and that is the behavioral health departments in most counties. That is the key role. That's who leaders look to for guidance, like who is really going to help this community with their substance use disorder problem. You look to the behavioral health departments. So you all are the key to all of this. While that said, most of the actual treatment, particularly the MAT, so most of the assertive field-based MAT will occur outside of the behavioral health department. And that doesn't need to change. You know, there's no current fiscal environment. You're not going to 10x, your current footprint. But all of those clinics and doctors and nurse practitioners and PAs that are out there, they can be converted into foot soldiers of access to MAT through partnerships. The most functional way to get that off the ground is to create a network of navigators in your community that spread across ER first, and then clinics, and then jails, and then shelters and street teams, and are able to talk to each other, and then are connected by a platform or some centralized line so that the individual walking around in the street can access it, can get into that network of navigators who are committed to help them spreading across behavioral health and physical health and other touch points. You put that together and you got a winning situation that's going to bring a whole, new generation of people into long-term care, and out of risk, and move the needle on opioid deaths in your community. So with that, I'll wrap up and pass it on to Anika.
In our final section, we're just going to very briefly highlight some other logistical considerations and dilemmas when developing models for initiation of MAT in this patient population. So one of the things you need to consider are health coverage. What processes do you have or will you need to develop to facilitate access to health coverage, including Medi-Cal enrollment? Recognizing that individuals who are likely to be served by AFBSS services have a number of competing priorities, including survival. And so recognizing that while our interest may be in getting them on medication for addiction treatment, that may not be their primary interest. And so whatever we can do to partner with other providers who may be able to meet some of those other priorities, trusted messengers in the community, is going to increase the likelihood that we may be able to ultimately deliver the medication once we've engendered trust, rapport, and met some of those other priorities. Again, hearkening on building a relationship of trust, using non-judgmental, empathetic outreach. We've already talked about how some of the medications, particularly the long-acting injectable medications, have some additional challenges related to pharmacy. And so having a relationship with local pharmacies, building specific processes or methods for medication delivery to individuals, specifically when you're talking about field-based services. If there's a pharmacy that can do some unique packaging for medications to make it easier as you're trying different initiation protocols, having a relationship with pharmacy where you know the medication is going to be stocked. You also know that individuals in the pharmacy are going to treat your patients with clients with respect and dignity if they do come to access and retrieve their medication from that pharmacy. Um, Trying to develop other strategies to ensure safe medication and storage if medication needs to be left behind with individuals, and then also integrating recovery supports. So these are all things that you would want to consider as you are building out models for medication initiation and AFBSS services for this patient population. And so in terms of some additional questions for consideration, there was one question that asked about saying a little bit more about the use of direct to inject protocols in unstably housed populations. And specifically, are there protocols that seem to be more effective than others? So what I will say is, again, this is one of those areas where I talked about where our clinical practice has evolved ahead of the research to inform it. Most of the data on direct to inject protocols were really based on kind of retrospective case studies, and so or case series, and I will say most of them were done in low threshold, low barrier clinics with individuals that were either unhoused or being treated in safety net public health systems. And so, yes, this was actually unhoused, high risk individuals were actually the population in whom these direct to inject protocols were initially developed and implemented. In terms of are there some protocols that seem to be more effective than others, what I will say is that, again, this line of inquiry is probably too early to say that there's one particular standardized protocol to use. What I would encourage you to do is kind of look at the research, look at the studies have been done, see if you can find a study or a report that looks at work that was done in a population that's most similar to the population with whom you're working, and start there. My colleague Andrew can probably talk more about the protocol that they used in the emergency department, where they used one single dose of the 24 milligram weekly formulation of long-acting injectable buprenorphine, and they found that to be effective. But again, that was done in an emergency department where people get a single injection and then are discharged to ongoing treatment elsewhere. And so again, what I would encourage you to do is to look at the literature, try to find protocols or studies that were done in populations that look most similar to yours, and then start there, recognizing that you will probably have to do some adaptation and modification as you go along to find out what's going to work best for your team and the population of individuals with whom you're working. And in terms of the next question, is MAT effective for individuals who are dependent on kratom? So this is another area where we don't have as much data. Kratom has been around for centuries and has been used for centuries, particularly in Southeast Asia, where the plant originates. But in terms of literature on kratom, we don't have a lot of literature on kratom. What we do have is there have been, again, kind of case studies, case series of individuals who had who were physiologically dependent on kratom, and buprenorphine has been used to manage withdrawal in that setting. And there are several papers that have looked at the use of buprenorphine for management of withdrawal for individuals who were on kratom. There have been there's at least one study that looks at ongoing treatment with buprenorphine for individuals who presented with kratom use. What I will say is that in most of those studies, the individuals had a pre-existing opioid use disorder. And so buprenorphine was continued in the setting of having a previous or even current diagnosis of opioid use disorder. But again, this is another area where we are starting to learn more and evolving our clinical practice. Probably faster than the research that we have to support it. But yes, there absolutely is data published studies looking at the use of buprenorphine specifically for individuals who are physiologically dependent on kratom. With that, I'll pass it to Mayur.
Thank you all so much for viewing today's webinar. If you have any questions at all, please don't hesitate to reach out to us at info@afbsstraining.org. Thank you and have a wonderful day.